the medical center is a tertiary medical center. You'd have patients traveling from Fort Kent for certain things. You know, it's a large area.
Okay.
Most of northern and western Maine. Speaking again just for EMMC, there are satellite offices in Orono, Bangor, and Brewer. These are primary care practices.
Right.
And on Union Street in Bangor. It's on the 990, but I think it's roughly 800 million. From a primary care perspective, there are other primary care providers. There's the Federally Qualified Health Center here in Bangor, Sunbury, St. Joe's employs some physicians. So, but I think competition isn't really, I think there is enough need for primary care, just speaking for primary care, that we could probably have more and still not meet the need. Again, the ACO starts basically off the patient-centered medical home model.
Okay.
So that's all of our primary care practices, again speaking just for EMMC, are all level 3 NCQA certified primary care. I think it's really, with all of the payment reform going on, and the fact that, again, I'll jump from EMMC to EMHS, the almost a lot of the spectrum of services provided, home health, long-term care, acute care, primary care, are all under one system. I think it's ultimately, in its final form, will come to it's going to be some sort of a global payment. Bundled. And as opposed to things that started in the 80s and 90s, I don't think this is going to go away. So it's kind of better to be in front than behind. We're going to be moving, we're going to start, ACOs have basically 4 different levels, starting with primary care and then moving into specialists and hospitals and population. We're going to be focusing really to start with on our own employees. We're self-insured, so therefore any savings that would come back to us. I think the initial plan is that we'll start in January 2011, like I said, with our own employees, and only focusing on the employees that are in our employed practices. In the second year, we also may look at, again, for those that are already in our practices, state employees or university employees. But in year 2, I think once we get some data and some experience under our belts, then we would probably be looking at more of a population. We also, Bangor is one of the recipients of the Beacon grant, so that's has a big impact. There's a lot of St. Joe's, PCHC are all working towards common definitions for care management, common measurement tools, common IT, or at least interface with EMRs. So the components are kind of being laid for what would happen in 2 to 3 years, where it would involve really the population of the greater Bangor area. Well, I think the benefit is that instead of there's not going to be any more reimbursement, it's going to be less. And I think the advantage of getting in early into some sort of a global payment arrangement would be that rather than having somebody come in and say, I want you to give me a special deal for orthopedics, I want you to give me a special deal for that, that it's really focusing on the whole cost and going at risk to lower that cost for whoever we're dealing with. I think at this juncture we're starting internally. I don't think there are too many real experts out there that know exactly how this is supposed to be put together.
Right.
As we move along, we'll undoubtedly have to get some assistance with some actuaries and other, basically data people. But I don't think you could, like contract with XYZ Consulting to come in and set the whole thing up for you. No, I don't think I think Geisinger and some of those are, pretty well set up, and some of the things on the West Coast are set up. But I think it's really going to be kind of trial and error. Probably less, no question, less money, I think, and ultimately decisions would have to be made about who gets what in the overall scheme of things. Because right now, everybody gets paid. The specialist gets paid based on what they do. The primary care gets paid based on what they do. The hospital gets paid. And if it's a global payment, then you get paid one thing, and now who gets paid what? Well, I think there definitely will be some drawbacks, I think, in terms of less reimbursement and kind of restructuring to deliver care in a different model, but I think that will occur over time. But again, there really isn't any alternative. It's not something you can kind of ignore.
Yeah.
I think the biggest challenges are going to be getting data that tells you where you are. Like if you've agreed to go at risk for X amount of money per member per month, you need to know where you are relative to that target. And there's the large insurance companies in the 80s, when capitation first came out, had the tools to be able to track a lot of that. But I think they no longer have that, so you're essentially having to recreate that.